So the session is an introduction into palliative care, and also how can palliative care help to support cancer patients. And the speakers tonight, it's Dr. Nadia Khan and Shakila Chowdhury, who are both from the Al-Amal Muslim Palliative Care Support charity. It's a newly launched charity. Dr. Nadia is a palliative care consultant who's been working in Birmingham hospice. She has sort of over 12 years experience in this field. And Shakila is a Muslim chaplain who's been working within various hospital settings. I'm now going to hand over to Dr. Nadia. Would you like to make a start?
Yes, Jazakallah khair. Assalamu alaikum, everyone. Many thanks for joining us today and giving us the time to speak to you, particularly Umbreen, who's put in a lot of time and effort to connect and get this set up. As Umbreen has said, I'm Nadia. I am one of the co-founders of Al-Amal Muslim Palliative Care Support, alongside Shakila, who is also here on the meeting with us as well, who will be giving her insights. So, inshallah, I hope this topic is of use for yourselves, particularly when you're thinking about applying it to the people that you are supporting, inshallah. And these topics may come up in conversation, or you might find that your patients have been either started on palliative care, or conversations have been had around the topic of palliative care. There are often a lot of questions about even what palliative care is, so we'll talk about all of that in more detail, and inshallah we'll have time at the end for any questions that you have. No question is too small. Very happy to answer any queries that you might have, inshallah. Okay, so we'll get started then. Next slide, please. So what are we going to talk about today then? So I think the key things are just really understanding what the role of palliative care is within our cancer patients, and understanding when a palliative care approach might be useful for your patients or the people that you're looking after, and when it might be suggested or started by the healthcare team. Who does palliative care is an important question. And then what is hospice care? So hospice is a part of palliative care, but not the whole palliative care story. But understanding what the role of hospice is very important. And we'll talk about some of the common misconceptions that might be out there in the community. I'll finish off by giving you a patient case example. So just talking you through the story of a patient and showing you how hospice or palliative care might be able to help support. And as I say, at the end, there'll be plenty of time for questions. Shakila will also give you an insight into specifically Al-Amal and what type of support is on offer, particularly from the psycho-spiritual care aspect, so the chaplaincy support, emotional support, and pastoral support as well, inshallah. Next slide, please. Okay, so first question. So what is palliative care? So palliative care is a name of an approach of care, and it's essentially really focusing on delivering quality of life for patients and families. So putting that at the heart and the focus of the goals of care for both patients, families, but also the healthcare professionals as well. So it's an approach that really focuses and looks to improve the quality of life for people and their families who are facing problems associated with life-limiting illnesses. In our context, often it's cancer, but it doesn't have to be. Other advanced life-limiting illnesses such as chronic advanced lung illnesses, chronic heart illnesses which are at an advanced stage, and neurological conditions such as motor neuron disease or advanced multiple sclerosis, for example, they can all potentially benefit from having palliative care. Most modern medical care, if you think about what the goals or the aims are, the doctors, the nurses, the healthcare teams, and even the hospitals themselves, all of them are set up with the goal in mind of trying to cure illness or to give treatments to control illness. So you'll know just how much money and research is pumped into trying to cure cancer, finding new treatments, or at least being able to offer treatments which allow control of the cancer for as long as possible. But at some point, there will come a time where it's no longer possible to control the illness and the illness is progressing. So in that case, what are we trying to achieve with medical care and healthcare? And this is where the role of palliative care comes in. Palliative care doesn't have to be just about the last stages or end of life, which is sometimes what people think it is. Actually, it can be earlier on as well, and I'll talk about that in more detail on the next few slides. Okay, so what is this palliative care approach then? What does it actually mean when we say focus on quality of life? So our understanding within palliative care is that a person is not just a hospital patient in a bed. A person is a human being, and we all have various different dimensions of our human experience and our medical experience, all of which is important to address and look after and manage and care for in order to get the best well-being and outcome for that patient. So in palliative care, we traditionally think about the 4 different domains or the 4 different aspects of a person. So modern medicine often focuses very much on the body. So it's about the mechanics of the body, it's the disease processes, it's the physiology, anatomy, the way that medicines are used by the body, that sort of thing. But within palliative care, our approach is really thinking about the human perspective and understanding that patients have different aspects to them. So you have the physical aspect, which is often what the focus of medicine is. But from our perspective, we are looking at controlling the physical symptoms that a person might have with illness, which is life limiting. So managing pain well, managing any other symptoms such as vomiting, breathlessness. There are other things such as the loss of appetite, fluid gain, ascites on a person's tummy. Those sorts of things, which can be really, really quite, when a person's struggling with them, it's an immersive experience. You can't think and you can't manage anything else because you're so overwhelmed by that physical suffering. So that's one aspect of things. But then we also have the psychological aspect, which, as you will know from your clients and patients' experiences, that's a huge component of the cancer journey. And from diagnosis all the way through towards the latter stages of an illness, there may be psychological distress or disturbance or even mental illness which comes about as a result or alongside the physical problems that the patient has. So anxiety management, depression, and then thinking about the social aspects of a person. With a life-limiting illness, a person's social role is significantly impacted, as you'll know. Often people can find that the things that have helped to anchor them into their families, into their jobs, that sense of identity, that sense of being part of a bigger network, being part of a community, all of that is impacted. And so us as social beings, we have needs as well, that palliative care looks to support. So sometimes it can be around particular practical issues such as financial worries or thinking about, what sort of benefits might be available. But also sometimes it's about thinking about that person's relationships with other people and the disruption that might happen. So isolation, loneliness, family support, especially if family members are struggling, relationships with children, relationships with spouses, with the wider community, all of those things may need some care and attention for people. And then finally, I say finally, but I feel that like this is the heart of palliative care. It's the spiritual support. So often when patients and people are struggling with life-limiting illness, very important questions around meaning and purpose come up. People can experience despair and hopelessness. They can have questions around faith. They can ask the questions of why me? Why am I suffering? Or why is this happening? Those sorts of we call it existential questions, and worry can be a big part of the person's journey. And you can probably imagine that all of these things are connected to one another and they feed into one another. So it's quite hard to manage one thing without thinking about all of the rest of the aspects. But the spiritual issues are often at the heart of what a person's journey is like, and can often be the thing that requires the most support, but is maybe the hardest to reach. And that's where our support from chaplaincy team, and Shakila will go into that in more detail, can be really, really helpful. Next slide, please. Okay, so when is palliative care? So as you can imagine, palliative care is for patients with life-limiting illness, but it may be that this approach is particularly helpful for people who are in the last 12 months of life. And this has been the traditional idea of palliative care, that the aim is last 12 months of life. However, this can be quite difficult to predict. That's one of the challenges. And sometimes people have got palliative care needs in all of those areas that I've just explained, but maybe quite early on in their journey. So what that means is that having palliative care running alongside even active oncological treatment is quite helpful. So we are trying to rethink what palliative care, what patients should fall under the palliative care net. And actually, you might find that there's various regions have different standards and guidelines and referrals in terms of who they will provide this particular type of support to or not. So it's helpful to find out from your local palliative care teams as to what referral pattern they'll take when it comes to patients and which patients they will see, because there is still some conversation about this. But I often find, from my perspective, actually having early palliative care can be very helpful in terms of not just symptom management, but also building relationships with people who will be able to help more when that kind of more severe problems arise during the latter stages potentially. So early palliative care has been even shown to help improve survival, believe it or not, even though we're not aiming to, necessarily prolong life in the way that modern oncological doctors are doing. But if you manage symptoms better, often patients can tolerate the treatments for cancer therapies better. And so that has an impact there. Next slide, please. Okay, so next question is, who gives palliative care? So palliative care is a very broad approach, and actually it's about giving the right care at the right time by the right person. And we can all be involved in palliative care delivery as people who are within the community and as family members, where we are giving that general palliative care support and approach, which is often around compassionate listening. It's about focusing on that quality of life element for the patient. But then you can also start to get more sort of a higher level support from the general practitioner and the district nursing team. So these teams are there to deliver what we call generalist palliative care. So they are a source of providing symptom management. So they should be able to do sort of, the kind of at least the basic level of pain management within palliative care. They'll be able to give guidance and advice on some of the common issues that might arise. The district nurses can give further information around practical equipment and support measures, and they can also manage sort of the commonly issued medications for palliative care patients. Then you've got another layer of support, which is specialist palliative care. And this is mainly delivered by hospices, but there are community teams and hospital teams that have been funded to deliver specialist palliative care as well. So every region is quite different. So you have to find out what's going on in your region and what the services are. But in specialist palliative care, which is the field that I work in, we tend to deal with the more complex issues. So if, for example, pain that's difficult to control from the GP's perspective, or the pain is particularly tricky because of where it's located or the type of pain, or if there's other symptoms that have been hard to manage, then hospices can provide that extra support there. The way that they can do that is by either helping people in their homes or they can help people in actual hospice inpatient buildings, which we'll talk about in more detail in a minute. The hospital palliative care team, just to mention, often what they do is they function as an advisory service to the ward teams for hospital patients. So you'll have your normal ward doctor and ward nursing team, but if they are struggling to manage a particular problem, which is palliative, then they will often get a palliative nurse or doctor to come and visit the patient and see what's going on and provide advice and support. So that's how the structure is within the UK. Next slide, please. Okay, so what is hospice care? So as I've mentioned, hospices are organisations that deliver specialist palliative care, and they are different to NHS in the sense that they're not hospitals and they're not care homes. They are they tend to be in the what we call the third sector or the voluntary sector. Hospices are most of them are actually charity funded, so they only get about a third of their funding from the NHS or from the state. The rest of it is charitable fundraising. And hospices are different because they're not NHS. They have different protocols and different ways of doing things, a different staffing ratio. So they're quite different to the hospital setting. Sometimes people think that hospices are nursing homes, particularly within the Muslim community. And it's important to sort of be aware of the fact that hospices are very different from nursing homes. Hospices are inpatient units, so in a sense they look more similar to being in a hospital, although they tend to be a bit more comfortable than hospital. And it's about patients having a short stay. Usually hospices will want patients for 2 weeks, roughly around that time frame, and then they're looking to discharge patients back home. And the aim for hospice admissions is to try and improve any particular symptoms or problems that the patient has. Inpatient care from a hospice is actually quite a small proportion of what hospices do. Most of the care actually happens in people's homes, where teams from the hospice, either a nurse specialist or a palliative care doctor or a caring team, can visit people in their homes and provide that hospice support there. I've already answered hospices are like hospitals. They're not. They are generally a lot more comfortable than hospital in the sense that the environment they aim to make sure the environment's more peaceful. They have a higher ratio of nursing staff who are very attentive to trying to ensure pain management is done well and on time. And because they have they've got a higher ratio, they have a bit more time to spend with patients as well. Although we are struggling with a financial crisis for hospices at the moment, so it is getting more and more stretched. But generally speaking, they're a lot more comfortable than being in hospital. And people often have worries about coming in, or they have a fear of hospice, but when they get there, they feel quite safe. That's always what I hear. I feel safe here, and I'm glad I'm out of hospital. That's what people tell me. Hospices are places where people go to die. So hospices are much broader than just end-of-life care. Yes, we do take people who want to be in the hospice for end-of-life care. It's a wide variety of reasons why people might want to be in the hospice. Often they worry about coping at home. They worry about family members having to manage that time. They worry about leaving memories in the house, and they would rather be in a different place. But a lot of people do want to be at home to die as well, and hospice care can support that. So hospices do much more than just end-of-life care, which is the last 2 weeks of life. We have services to try and help people to live well for as long as possible. So this is where early palliative care comes into play. So we have places like day hospices, which are focused on improving the well-being of people. And then we also offer clinic appointments, for example, which feels quite similar to seeing a doctor in a GP practice, that sort of thing. And final myth is that I have to pay for hospice care. So you don't have to pay for hospice care. Hospice care is free. It's not private care or anything like that. But as I've said, most hospices are charities, and they do take donations and are quite reliant on donations as well. Next slide, please. Oh, I've got a few more myths. Okay, so hospices end up filling you with morphine. So this is often a very common concern that people have, particularly people from the Muslim community are concerned about this. Um, from our perspective, towards end of life, it's very important that people are able to be as alert as possible so that they can engage with their ibadah and be able to say the shahada as the last thing if they are able to it's possible for them to do so. People do worry that staff may not understand this and therefore just be very liberal with the medications, especially morphine. But working in palliative care, so me as a palliative care consultant, my experience and my practice is that we only use medications in accordance with what the needs are of the patient. So yes, there may be patients who come in who are in extreme pain and we need to increase their pain relief to get them comfortable, but we don't go from 0 to 100. It's about increasing up the pain relief at a staged level to the point where a person's pain is comfortable and they are either managing on that level, or if they're having side effects we can think about other medications. So the goal is very much not to just end up filling people with morphine. Sometimes people do need quite high levels of pain medication in order to be comfortable, and that's as the scenario or the situation requires. But very much we use medications carefully and we use them with full conversation with the family and with the patient about what benefits there are, but also what potential side effects there might be, and allowing the patient and the family to have that conversation and be part of that decision making. And last myth that I will talk about is that hospices won't meet my needs around cultural and religious requirements. I would say that hospices are a lot more aware of the cultural and religious needs than maybe you might find in hospital. And we do tend to try and meet that because of that model that I showed to you earlier, where we understand that a person is much more than just their physical body. There's a lot more: the spiritual need, the social need, the psychological need. So generally speaking, hospices will be very open to hearing from you what's important to you, what's needed by you, and they will do their level best to support that. So it's just about opening that conversation. Next slide, please. Okay, so I'm going to very quickly go through a case scenario around how hospice can support a patient. This is a hypothetical patient, but it's a common story that I hear, and then I will hand over to Shakila to talk a bit more about Al-Amal, and particularly from her perspective as a chaplain, how she feels that we can best support patients in palliative care. Right, so the patient we have is a patient by the name of Farah. She's a 45-year-old lady who has lung cancer and bone metastasis. So she has involvement of the bone. The cancer has spread there. She's having cancer treatment, but she's struggling more and more with feeling physically tired and fatigued, and is also getting more infections as well, which the GP is giving her antibiotic courses for. She's waiting for her oncologist to see whether her cancer has responded to the third line of treatment. She's very worried about the results because she knows it's the third line and that the chances of success are lower as time goes on and the treatment options become more limited. But she doesn't want to tell her family about this because she's protecting them. She has pain in her leg, which is not controlled on the cocodamol that's been started by the GP, and it's waking her up at night. From the social history, we know that she has 3 young children and she has had to give up her job in retail because of her illness. Next slide, please. So the GP is struggling with knowing what to do next with the pain control, and so he refers on to the hospice. The community palliative care nurse gives Farah a ring and agrees to come out and meet her. And the role of the initial visit is really to get an idea of what Farah's needs are. So it's understanding her holistic needs, again, in all those 4 different areas, and understanding what's important to Farah and what the current issues are for her. The other thing that often happens on the initial visit is that the hospice nurse will explain what the role of the hospice is and what services there are. It can be a bit overwhelming for patients when they hear the word hospice, and so often there's a need to just show a face, show that that person is warm, friendly, that they're able to trust that person. So building up rapport is very important. And that's all kind of, it can take up to even an hour visit on that initial assessment to do all of that. So as I say, there is time that the palliative care nurses have compared to primary care and hospital. So the nurse gets some help from the hospice doctor, who advises to start a low dose of morphine to improve Farah's pain. And she's also able to tap into other services within the hospice. So here she is able to get advice from the hospice physiotherapist to help Farah around movement, especially with her being in pain. So hospices, apart from nurses and doctors, will often have other team members because of those holistic needs. Me as a doctor, I can do certain things, but having a physiotherapist to help, or an occupational therapist who are looking at things, problems from a different angle or a different perspective, they will have ideas that I won't have. So it's really helpful. So the CNS visits Farah a few times. Farah is able to develop that trust relationship and is able to open up about her worries. So we are aware that things can take some time and people can't be rushed. This is a very emotional and vulnerable time for people, and there's a lot often going on underneath the surface, which takes time to disclose. So she's able to signpost to financial support advice through the hospice social worker, and gives Farah advice on speaking to the children's school as well. She offers Farah support from the hospice psychological team. So often hospices will have some form of either psychologist or counsellor team who can help with some of the psychological processing. But in this scenario, and as is often the case, Farah doesn't want this. And there's no compulsion to have anything in hospice that you're not comfortable with or don't want. Next slide, please. So the oncologist finds that Farah's cancer is progressing despite treatment, and he says to her that he will see her when she's strong enough to have treatment. So that's often a phrase that we hear. It tends to be a bit of a stopgap phrase, where sometimes the oncologist probably knows that that person's not going to be well enough to have further treatment, but it can be difficult for the oncologist to maybe broach that, especially if they've got a long-standing relationship with that patient. Oncologists are, can find it hard as well to accept that we're coming towards the end of the treatments that are on offer for the cancer itself. That's not to say there's other things we can't do, but that can be quite challenging for oncologists. So often we do see that. Farah carries on losing weight, getting weaker, and becoming more unwell. Because she doesn't have clarity on what's happening, because she's waiting to see if her cancer doctor will see her when she's strong enough to have further treatment, she has lots of questions, and she's struggling to come to terms with the changes that are happening, and she feels like she's failing both as a wife and a mother. So there's a lot going on for her in terms of her inner journey, her inner world. The community nurse is able to have a sensitive conversation with Farah and her husband to find out what's important, although this is a very difficult conversation. And as hospice team members, we do have training in advanced communication skills to help us to open up these conversations and explore them. And it's very important that this is done in a delicate and sensitive way, but also being able to have honest conversations can be very important as well. Because sometimes it's the fear of the unknown, which is the biggest thing. But you have to judge it. And that's part of the skill of palliative care and psychological support. But Farah discloses or says that she wants to really spend as much time as possible with the children, and she wants to get her financial affairs in order as well. So that's something that the CNS can help with. Next slide, please. So one morning, Farah becomes very unwell and confused, and she's unable to get out of her bed. Her GP sees her urgently, and he thinks that she's approaching end of life, but is not sure. So often sometimes there can be uncertainty for doctors and nurses as to what's happening. And sometimes hindsight is a wonderful thing. Like, you can see the pattern and say, oh, this happened then and this happened then, and it was pretty obvious what was going on. But when you're going through it, sometimes it can be a lot harder to know. With skill and experience, it does become a bit easier, but still we know that doctors are not good at prognosis estimating. But nevertheless, the GP is not certain, but he discusses with the hospice team because he knows that Farah didn't want to go back into hospital again. So they decide to admit her to the hospice inpatient unit for symptom control, but possible end-of-life care. And here in the hospice, she continues to deteriorate quickly despite being given further antibiotics. And it's clear that what's happening is that she's approaching end of life. She dies comfortably in the hospice 4 days after her admission. And because it's been recognised, it's been identified that she's dying, the conversations have been had with the family who can be there at her bedside, potentially support the children and prepare them. And the hospice can also access Muslim chaplaincy care, which is really important. So the questions I want to leave you with, just to think about before I hand over to Shakila, is that what would have happened if the GP had instead transferred Farah to hospital? Would she have received any other treatment? What would her care have been like, particularly in her last days of life? What would her experience for her family have been like? And what if Farah had expressed that she wanted to be at home in her final days? What would that have meant in terms of planning, and what things would have needed to be put in place? What conversations would have had to be had? What sort of support might have needed to be in place as well? So these are all things that if you think about in advance, you can do things to try and improve the situation as much as possible to make it as easy and as pain-free and as least distressing as possible. So I will hand over now to Shakila. Next slide, Ambreen.
Assalamu alaikum. So Nadia's just obviously explained kind of holistically that palliative care looks at all aspects of a person. And from the chaplaincy perspective, I'm a Muslim chaplain. And one of the roles that I play is to offer emotional support, Islamic guidance, and spiritual reflection. So quite often patients will come in, they know that they have an illness and their body or their physical body is obviously going to deteriorate over time. So that's something that is, they're quite well aware of. But what happens with that is there's so many other things at play. For example, they may be now reflecting on their life. Some people have been told they haven't got long to live, and so they're now looking back at the life that they've lived, so they're reflecting back on their life. For others, it might be that they have questions about what next. For some, it's about understanding their purpose and meaning right now. And quite often you're sat with these thoughts by yourself and you think, well, who would understand this, or who could I share this with? But actually it's quite often you're feeling distressed from all these thoughts that are running past you while you're trying to manage this illness. And that's where a chaplaincy team can come in. So a Muslim chaplain can come, sit beside you, allow you to have those conversations and sit beside you while you reflect about life. So it could be that you want to make sense of the life that you've lived so far. Some people will come forward and say, I have many regrets and I don't know how to move forward, or I'm too scared to move forward. My journey might be coming to an end and I can't make sense of this. How can I correct this? So quite often we will talk about and in Islamically we say you shouldn't reveal your sins, but sometimes patients feel the need to share something because it's so heavy on their heart, and then to be able to make sense of that, and usually that might include a journey of making tawbah, and looking at the relationships they have with Allah subhanahu wa ta'ala at the moment, and how that how they want to progress moving forward, because we want to return to Allah in the best possible way. And one of the things that we can support in doing this is sit and have those conversations, allow those emotions to come out and be addressed. A majority of our work is about active listening, is really being present with that person, but also understanding that wherever they're coming from, it doesn't have to make sense to me, but it needs to be so that they're comfortable from in how they are at the moment. So along that, we'll have a lot of kind of questions that patients might have. So they might want to know, is it okay for me to sign the do not resuscitate form, you know, if from an Islamic perspective. So they might ask the chaplain these questions, and would kind of give them the guidance and the answers behind that. A lot of people will say that they have concerns about using morphine. And what about saying the shahada at the end of time? So this is kind of more end of life stuff, but along this journey, you know, you have various aspects that will come to play. So you might have family who are not coping very well, and actually the patient wants to talk about how their families are coping, and sometimes they can't share things with their family because it would make things worse, you know, or family are not coping very well, so they don't want to share it with them. They'll come to the, you know, they could reach out to the chaplain, would be able to sit with them and have those conversations, and even maybe help in making those connections a bit better between the families. Kind of consider, how could we have conversations with them so that there is better understanding between family members and the patient. So it's very much patient led, and it's about wherever they're coming from, whatever their needs are at that moment in time, and we will sit beside you. And I think with chaplaincy, we're really trying to journey along with you, and that's quite important. Whether it be from the aspect of the deen that you would like some support, or emotional support, or even just understanding the practicalities around your illness and how things are progressing. So, and again, we work very closely alongside the medical team, and try and, you know, kind of work together to make sure that holistic need is met. So one of the things that myself and Nadia have found is there is a gap in palliative care in providing spiritually, well, Islamically aligned and culturally relevant support. And so we've both been working in hospice care. We've been providing within our own roles as much support as possible, and we've both noticed this gap, and I guess we were both trying to fill that gap ourselves. So we've kind of come together, and alhamdulillah, we've managed to produce Al Amal, which is a platform for Muslim palliative care support. So we're not providing the medical support as such. That will be done by your healthcare provider or your doctor or your consultant who's in charge of you. What we're offering is a telephone and email based support where we can offer you emotional and spiritual care. You could request for that support, and one of our team members or myself would give you a call, and we could spend some time talking on the phone. We can help you understand your medical decisions. So quite often within the journey, you'll have lots of things that come up medically. Sometimes you need to make decisions, and sometimes the doctors will tell you, they'll recommend things to you, and you might just want to understand your choices better. We'd be able to help you with that. So if you were to reach out to us, Nadia would be able to guide you and help you understand those medical decisions. We've also, could we have the next slide, please? So we've also developed resources on our website. We've got leaflets that are addressing many of the kind of concerns that we've come across in our work. So as you can see, this is one example of our resources, and this leaflet is, should the doctors try to restart my loved one's heart at the end of life? So this is one of the common questions that we get, and it's important that, you know, we have this information available. What was happening from my perspective is patients were coming to this point where the doctors were having this conversation with them. They were not sure whether they could sign this. They were either having to reach out to the local imam, they were looking for somebody that might have knowledge about this, or they were asking for the Muslim chaplain. And then just simply asking that question, just getting some guidance on this. So what we've tried to do is collate as many of these questions or concerns that we've had to address over the years that we've been working in palliative care. And we've tried to formulate them into leaflets that will be available for you to download, read through, keep as a reference point. But this will also allow for healthcare professionals to also turn to our website, look up those kind of common areas. Maybe there might be a leaflet that we've created on it. They could print it out. The main aspect of this is that this is all Islamically aligned. So inshallah, you'll find that the queries or the questions that we've asked in the leaflets have been addressed from an Islamic point of view. And hopefully that allows us to have that kind of gap met a little bit. On top of that, if you needed extra support in understanding things, or if you wanted to discuss this a little bit further with us, so you may read the information and have a second, kind of a second opinion on it, or you may think that I need to understand this better, we'd be able to provide that support if you were to reach out to us. So we've got within our resources area, we've got the understanding palliative care. So we've got lots of leaflets on just understanding what palliative care is and what that looks like, navigating the journey. So really from the Islamic perspective, you might have something like one of our leaflets is to do with my loved one is approaching death. How can I support them? Preparing for end of life. So as a chaplain, quite often we're asked to help in funeral arrangements. And understanding what the kind of needs are at that time for families, what their expectations are, and how do they go about doing this. So we'd be able to offer you advice and support on that. If it's not within the leaflets, you could always reach out to us. We've created some leaflets on different types of du'as that you can use. So while for yourself and for your loved ones, and after death. And we've also created a healthcare professional series, which alhamdulillah is for the healthcare professionals. So any medical teams who are looking after palliative care patients, if they needed support in how to look after or best way to kind of manage Muslim patients and what their needs are, then we've got alhamdulillah, we've got a couple of leaflets at the moment, and we're working on developing some more, and that will give them some guidance in how to, what to expect with Muslim patients. So we've created one, for example, on Ramadan and what the expectations are in Ramadan. So number one, they'll be able to understand what Ramadan is all about, but also how they can support someone in palliative care during the month of Ramadan. So alhamdulillah, Al-Amal is kind of, we've launched very recently. And we're hoping that, it's a service that, the community can reach out to, and hopefully we can kind of fill that gap and add that extra layer of support, inshallah, for palliative care patients. That's it, really. So if there's any questions.